leaving all things arthroscopic. I have been running these talks for 2 or 3 years. We started off during COVID time, so we went online. And I've been very blessed in that Helen and Kerry have attended the meetings and contributed quite a bit to my understanding of business. And so that this was planned is to have a LO and practitioner and myself addressing the topics that we've discussed so many times before and doing a collaborative style sort of process. And so just to sort of introduce the concepts to GPs as well, and obviously non-patient patients, so you can picture whatever you want. Kerry has been here longer than me. A very senior occupational therapist who has persisted with an interest in hands the whole time you've been here. But you have the full breadth of occupational therapy in your practice. And she has recently been joined by Lyndon, which you might be able to see on Facebook, who is going to focus on hands. That's the strategy? Yes, that's what my understanding. And so, we haven't quite talked about how we're going to structure this, but I think if we're pitching a little bit to GPs, I might, can you flip the next slide? I think you can do that, so I can resolve it. Yeah, try that. I can't see that. Give us the next one. Okay. So I think I've gone, I'll do diagnosis, treatment options, complications, outcomes. The other thing that both of us like to do is to give it that regional focus, which we've got a different approach, I think, in a lot of ways to treating patients because they are geographically displaced, they do present late, they're a unique subset of patients, and sometimes they can give you a real fright because they're quite complex, or they can give you a real fright because they present. So when I'm looking at examining the carpal tunnel, I'm chasing the history of the classic symptoms. Carpal tunnel has always been a very clinical diagnosis and not so much a testing diagnosis, but like this care that's had that real MRI focus. So I'm always looking out for a positive valence test. So as far as I don't know if you want to talk about history, but as far as examination goes, I like to report augmented valence test. And I always tell the GPs I like that one because I flex it up and then I put pressure on the flex of it active. Sorry. I put pressure on the flex of it active at the same time. Yeah. And instead of a valence test, which is sort of 3 minutes worth of pressure, I would cut it down to about 30 seconds. As soon as they get any sort of, I think that's it. Then I count that as a positive. The reason why I do that is because I want to know if it's there or if it's there. If it's there, I'm out of there. I don't. So I say them, there can be that double level crush and it can be dealing with 2 injuries, but my department is the hand and I can help you with the head, but I can't fix your neck from here. Even with a really long issue. So therefore, I want to know the clinical diagnosis. Yeah. I do sometimes do a TNL test, find it very variable. Durkin's test, I was showing is pressure in the overflexive tendons. It's supposed to be painful, but I've seen 1,000 different interpretations of Durkin's test, the Cairns test, and it's not that optimum. The thing I've got on the picture is a very wasted theta eminence. And I love Kerry's take on this one. I believe the wasted theta eminence has 2 causes. One is osteoarthritis in the base of the thumb, and 2 could be carpal tunnel syndrome. I think it has to be a very late carpal tunnel syndrome for it to be atrophy. I think it's probably wasting from pain due to the base of the first metatarsal. Love to hear your relationship.
Yeah, I don't want the first thing to see to be the wasted.
Really, there's a lot of that. Yeah. But they can do sometimes.
Yes. Probably much more. There's stuff that can be done non-surgically if we can get them early enough. Yeah. So ideally, then GPs who waking every night with pins and needles and, you know, shake it out, or I've got a change competition, or I can't get comfortable, or I've started to do
Don't think too bad.
and most of us have had this at different times, and it was really interesting. I had Carpal when I was pregnant, and you know, the extra swelling into my extremities meant that there was a lot of pressure on my body and nerve, and also pressure lines. Was really important strategy, but it is meant to help me keep me neutral at the wrist when I was sleeping, so that I wasn't feeling nothing that was in the family position, in the position to really pinching on the nerve. So the other thing I find is people need to know about nerve spiders so that they can gradually get the whole process of the pathway, gathering length in the nerve at every point so that it isn't being moved. The other point, there can be compression on the nerve through and so that's the fraction collapse test. You know, which I always am using if I want to make it feel for the fraction sleep test. This is the big old things in magazines, scratching. No, it's not that test.
It's not that one. But it's that is a very happy patient as well with that pronatal compression syndrome, because they get hand dysfunction, and they're all confused. No one's giving them a diagnosis. They don't know what the heck's going on, and it's a small operation hand. You get away with something easy. It doesn't have to be a big deal, but it's the diagnosis.
And the carpal tunnel piece. Yeah,
it's not going to fix it.
Yeah.
The only thing I'd say about waste is if you're actually looking at an atrophic thumb, if you're looking at atrophic thumb and they have no paresthesia, no tingling, no carpal tunnel symptoms, you don't need to necessarily do anything about it, because now that I've mentioned it, you can see atrophic thumbs everywhere, because there's an awful lot of basic arthritis. Then you sort of go, oh, that's another one. So you don't actually have to do anything about it if it's just arthritis. They're asymptomatic, no pain, no paresthesia. But once you see that, you know, I think that's a fair thing to sort of go, honestly, why is this patient got absolutely? So if you think they've got carpal and they've got posting, then that is a reasonable time period. Before that, you can treat them
and there's things you can do therapeutically for as a therapist and the surgeons for CNC based. Yes, CNC on LA, and you don't want people getting that diagnosis and going, oh, it's just arthritis, it's nothing we can do. There is stuff we can do to help them manage. Actually got all of that. I had my favourite trick for that.
I know, you got it?
Yeah, right.
Yeah, go on, get on.
So, can I have your hand? So, one of the biggest things, can you see maybe?
I think that's what I mean.
So, I often get our nodal cramp here. It's spread. It shows that base of thumb here is a saddle joint. So, this is the saddle. There's the rider on the saddle. And if you are sitting on the saddle, Popeye, you're going to get a really sore bottom. So you should sit on that. My guess is, even if you did a saddle, language. But if the muscle in the first ribs are tight, so the thumb, adductor, and the first interosseous are tight, it will pull the rider off the saddle, and so it will not sit evenly. So bone will rub more and be more regenerative. And often when we feel a new term, we will find these jumpers that it's getting top of this screen. Stop share. So very mind. Keep going up to your right. That's it, it's stop. So these muscles will be a sound in the front, but you can't here. We're looking at these muscles. And so what we use is a big peg to go into those muscles and sit like that, 30 seconds at a time, and then we stick it somewhere else, and it just helps do this. But if I do this, what I'm doing is loading my other muscle. That needs to also rest in all likelihood. So the big peg, which these are called pegs, HEGS, and you can buy them at Coll's or online, and you can find them in the laundry. So you can find other ones that, if you are clever, you find a magnet version that you keep some notes on the fridge. But I have trouble finding them. So these are cheaper and smooth and safe generally. Sometimes there's a tiny little bit of roughness that I sandpaper off. But yeah, it goes in there, helps release that muscle, and it's amazing how many people have a lot of extensive pain here, and it's a nasty pain. You want to put your shorts up and you go, ugh, you don't even know what's going on, because you can have pain in the wrist, you'll have pain in the joint, and it is awful. I drove to Cairns for one day and spent a lot of time flipping my cruise control up and down and on and off. And this wasn't doing anywhere near as much, but I got there and then was thinking I was going to have to ask someone to help me get dressed, which was a family, but it was awful. Nasty, sharp, into pain, but the peg helped a lot. So you don't have to use anything else that gets in there. So sometimes a key, or broad pressure. Yeah. But it's about teaching those muscles to settle down. Often, probably this one on you. Tiny it's nice and dry, so you can kind of see that this means she's probably lost a lot of time. Yeah. So you might. That's right. Yes. So there actually is a 3 point for all sorts of things that yeah, we've forgotten it. Yes. Yeah, something. Yeah. But there you go. So look, we wouldn't benefit from having that. Is there a reason we shouldn't do that for another acupuncture point? I've never done that. Right. And they used to use it. You said be able to do that, and you could do it. You said that boil from salt. Kerry was out. Always. No, I know, I was scared of it, that we were more things like something.
So history of examination. So just to restate history, what I'm looking for in history is in the needles, tingling or numbness. And I do find there's a language barrier for tingling. So often if I've got a backpacker today or any country, I have to be very clear about what tingling is, or I have to be very clear about what pins and needles is. And I sometimes I almost have to demonstrate what I mean by that, because sometimes I don't quite have a language for that. I have people translate that quite a few times just to get the word right. And then I try and get them to distinguish from numbness, and sometimes they haven't got that. So they haven't quite got the difference between tingling and numbness. They see it as one entity. And then I try really hard for them to tell me which finger it is. And so in theory, I'm supposed to say that the radial finger is not the ring finger, but I see the whole variety of the spectrum. See people with predominantly middle, predominantly finger, predominantly thumb, and do often see the finger included. So a beautiful study that said if you miss a couple times, it does seem to help you on the maybe reached, not sure. So I do, with my heart in my mouth, I do sometimes operate in the reading of the things involved. My preference is to refer to nerve conduction studies, but the nerve conduction studies very hooked up. And so if I can arrange a meeting one, but I tend to try and get the diagnosis right. So history, paraplegia. I do also ask about have they had episode before. And there's two patterns for me. I see up and down like this, over 10 years, they've got flare-ups, and then I also see the few 4 weeks, it's just really send them off the scale. And they often have a lot of different things. They have concurrence with properties, and so I sometimes treat them with steroids, and then I sometimes treat them with surgery. It just depends on how perilous the nerve sort of appears to be with that.
I can remember someone that had they had an industrial incident in the workplace. They had been required to remedy it by shoveling for a day, and that was enough to settle this ridiculously huge problem with bilateral acute. That's pretty rare because most of the time it's either that we call an occupational abuse or a cumulative trauma disorder, so that it is basically occurring with the build-up over time, and that it's the different things that people are doing. So the forceful and repetitive gripping, the very repetitive movements that might stir up that area, and I often show them the diagram of the cross-section because we talk about, there's the bony layer, there's the band on top that holds everything in place, and the first kind of simplified on the top and get pressure easily. Yeah. So,
something I never been able to.
No, I'm nervous.
So you got carpal, and you wake up and you move it or you put it down. Yeah. Doesn't that mean that you're actually getting better circulation to your nerve to increase the symptoms?
What do you mean? Why do they do that?
Why does it work?
You're taking the pressure away from them. So often when you sleep, you're being slight motion of extending your wrist. And so rather than shake it.
To me, I think it allows circulation to the nerve, and that's what happens at night. Like
it is compression.
There'll be compression on
the circulation to
the nerve. Yes. And because why don't you get it other times? Like when you're asleep at night, the blood pressure decreases and have less circulation.
You have increased peripherally. So one of your Gibson had a jar, a tall jar next to his bed, and he put his arm in and measure it off. And then in the morning, put it on again, and then we space the water space about 13%. So we're very slow, 30% of them.
So why?
Which legs don't do.
I've heard the blood pressure decreases. Females' blood pressure more,
and that's why
they actually do worse.
Fascinating. It's a very large range to study this.
Oh, no. But what, or no, there's no pressure on the nerve. We have confidence dedication coming from, when we have numbers from the but we have
we've got
more dedication coming from
signal being sent to the nerve.
When it's not working on its way to, we know we're not getting the nerve is not working in place until that happens, we're actually getting more signal. And when you do the coin test, they're actually older on that stuff. You've done that coin test? So because more likely it's the small nerve fibers. That's why you have the nerve conduction test and it doesn't show up in the they've got in the median nerve small fibers. So there's there's very established small fibers test. And so instead of testing this for conducting fibers, whereas if you put a Coll discrimination test, so you put with Coll there, and then they have got Coll. So they've got more.
Altered sensation.
Yes.
Whether the tingling is an abnormal impulse generator concept.
Yeah.
So something's not right.
Yeah.
In any case, which we know can settle if we can take away the extra pressure on the nerve.
Or we move.
So this is all move. Yeah. So in the early days, yes, just a bit of movement or taking it out of that position can help solve it. When that doesn't settle, and then you get in the needles or numbness in the day, and you're not your knife at work or whatever,
then you're getting
then you
pressure.
got something going on.
when I operate, the synovium, the normal synovium of the carpal. So the carpal, so every tendon has synovium. So the lining has synovium. That has varying. So sometimes because I do endoscopy, I got a 4.7 millimeter tube. So sometimes I put it in there and it's loose, like it doesn't really feel tight.
Like it's not really not complete.
But I think in those patients, the synovium is really, so that synovium is inflamed and finished throughout the day. Sometimes the actual bulk of the synovium is only be enough to impress it.
Or it's not working. Yes. No, it's not going to get it.
Yeah, that's what it kind of feels like. Instead of being like tissue paper, it's like thick and leathery. And so I think it's got this, like it's become the chronic side.
Yeah. Makes a difference over time too. I think how quick you can get to them and things like that. So I'm not sure if I'm right or not, but I had something the other day that was actually released. They said, "So what did she actually do?" And I go, "Well, this is so unfair, but I'm going, well, let me put a bit of tape on here and look at this. See, it's cross there, and she literally goes this, and
Don't get that through.
well, it could be so many surgeries. Well, not learning the process. Yeah. But this also helps to explain why I might end up with foot pain or here and here. Yeah. Because the pressure of these structures learn their new place and it goes back to correctly.
If you go back in after 2 months, there is something to cut. Right? It does not look like it's nowhere near as thick. And particularly, sometimes this end here, it's almost like it's a rolled edge on it. It's really hard, that's it. And so the replacement flexor retinaculum is there, but it's not sort of as robust. It doesn't have the transverse fibre.
Well, that comes next week, but sometimes found that a lot of trouble down track is that she's not managed to get because they'll often end up really dense, really swollen through the carpal area.
Yeah.
And it's not the external scar that's the problem, that's really usually nothing. But it's the stuff underneath that's gone all big and dense.
So, do you have many that you think it's lymphatic?
Not a lot, and they say unless they've got a specific lymphatic issue, which no other things are swollen in the hand, they might have had nodes damage to the accident of breast cancer surgery or whatever, which they've been managing. That is
much more subtle.
It's a different tissue. It's like in person, is more like a CRP, not quite like a CRP, but it's a softer swell. Yeah, like when I look at it, it's different. It's like it's more like a woody edema than a lymph edema.
There's a continuum too. The longer the swelling comes out in the hand, the more thick and stodgy it goes. So I often describe that as fluid should river like water running by. Some fluids by swamp story, and if it gets caught down there, it is just like a river that's got diverted off into a swampy area or a billabong that goes thick and stodgy. So you've then got swamp hand.
Like Carpal Spa. If you ever go there, think you're going to see Carpal Spa, and then that's it. It's just very. But no one wants to.
They all look at work getting out of their swamp. No one's taking the chance. No. No, they're not draining the swamp. This is about moving the. They're not going to go. But yeah, managing swelling and using things like it could be as simple as studio. So if their fingers aren't swollen,
it's all rolled up and looks terrible.
sorry, studio then it's useless. You can replace regularly. It's not looking right.
As soon as it's not looking right, you can say,
well, you can trim it down if it's just right at the ends, but it's just it does need to have compression. I don't just about nail out use a double thing, so you will because it's often too much for the more distal and they'll swell here.
the fingers as well.
The fingers as well because it's got too much here. So there's always a risk to risk. Oh, there's a good one. Because this is very cool. That if we just focus on compression over here, we're going to have way too much pressure and the movement. So you're not allowed to swell anywhere else. They've got to have good graduation pressure.
Yep.
So that's why we had like that lymphatic drainage training as well. But if we're not going to do that, we might go into a compression style like this one. So either pre or post-op or both.
So how do you apply compression?
Get rid of the swelling. So we're not compressing the nerve, we're getting rid of the swelling out of there, and there's often swelling because there's the synovial fluid is caught getting stuck there. So these ones is the brand Harry Morco, that's just one of the brands. Other ones that have usually they have to deliberately that length. They stand shorter. Yeah, no, shorter is usually useless because your fingertips you get mushroom fingertips in that right. Yeah, and you like not usually. I like it. If there's swelling, and everyone's fingers different length. So if that's not good and there's swelling beyond that, then you need a full finger version. But we don't want to go there very often because we want the sensation that they might still have in their fingertips. Yeah, but it's difficult. They also need to be sized correctly. So you've got to have a lot of fits. So any well size and going from the internet, and so how do you know it fits? So it can't be easily done in between, but it can be easily picked up the seam.
Got it? Not in between, but at the seam.
Yeah, so on the palm, there's like baggage there, but it shouldn't look loose. Yes, I deliberately brought one with this my size because then it's like it fits. But if we put this on you, it may not look so right. So but that's the other option. And then that we can tell because you can take a circumference measure with a loose fist, which helps sign that we can do a size chart. You know? Yes, right. Size chart. Then there's another one that we often use that's called the I'm Active, which is got the constant grip dots on. And so you size that one using a flat here, and so I'm meant here. So right on the border of small and the scattered. And these ones always come in 3/4 inches. And obviously, watch on the front to manage swelling that often as well. So often post-op we have to go into the northern one first because they're a little bit more stretchy, so they're easier to get on, they're easier to cope with. Really good for managing swelling because then they'll get them during the retrograde massage, if you like. But this is better functionally, so anyone who's got more prolonged swelling we usually end up in the active because it's quite a bit more. It's not tight, but it is just a little bit more resistance, which gives them a bit more control of the swelling. Anyone with hypersensitivity generally tolerates these. Yes. So it's really carefully grading which glove and which fit, and then a couple of them actually recently have gone into a thermoskin glove as well, which is the heat retaining glove because their hands going. It's more than you can get like mine. I was hated them on the present. I think they make the hand really hot, but table lamps and people that have got neuropathic weirdness going on. So I can pass that around. Yeah, because the neuropathic, they're probably don't like Coll. No, well, it's got an extra Coll. and it seems like a weird fold, and not equal to the other side.
Don't use to it. What are we up to? Treatment? You want to do, okay, so let's give you a case study. Let's give you a weeping 32-year-old pregnant. She's well, let's make it early. Let's say she's only 4 months pregnant. She's got 5 months to go. She's waking every night, shaking her hand. She's got a 3-year-old and a 5-year-old, and 100 weeks away. 5 more years. That's that's what they do. They go up and you watch it and they go back.
Steve needs a lot of education and careful education. I would fit her with a compression block and a wrist brace.
Wrist brace? Tell me about the wrist brace.
So this is my, yes, it does, but it doesn't have to. Point. So this one actually blocked on the bar rail. Check it out at some point. So these are my favourite ones because we tried all sorts of remade ones. They tend to fit. So again, you've got to be sized right. And when people get sent off to the pharmacy to buy them, they get the size right. They're often one size, not left or right specific. And in order to get a good fit, you need to be left or right specific generally. As well. So there's meant to be a bar in there, there's meant to be a bar in there, so that it stops the need for like when you don't want it to come back into a lot of tension either.
Yes, yes, true.
When you're resting. So what the brace tends to do is help them to rest properly and then recognise, well, in the past I was doing a little bit more keen to having a few days. Part of it is I'm going to do an assessment of what they're doing that's stirring up. Now, if it is the outcome related to pregnancy, then I might change my mind. But if they're clearly doing a whole bunch of repetitive use stuff in the day, I might deliberately have them in the day as well as overnight.
To try to restrict them.
Okay. And to try and get through to the day, got to keep them as neutral and not keep them reflection and just have a whole lot.
And that case study in the pregnant woman, is that usually a bilateral circumstance?
Yes. So it's much more tricky when they're bilateral because you don't want to bilaterally brace them. But you might do the worst. They'll often be a worst hand and or the dominant hand.
Or would you do hour on, hour off?
Well, they're going to by choose both. So they might not want to do that at that point, particularly if they're coming up on only a month and a half left or something.
Right.
But it can happen usually.
It stays up.
It does. I did my own test.
And then you add the drums.
Yes.
And then you got the video.
You're right. There's some nerve pain. Frequency there after. Yeah,
Just pull out of pregnancy.
Yeah, just know that it's the pre-pregnancy. Is were you working, doing specific things with your hands pre-pregnancy that might be stirring it up? Yeah.
I know these videos, like bit of a change in role tasks.
Yeah. No, I don't hear that. Oh, yeah, but what I want to do is always hear their story because they will have a theory and we either need to help educate them about how that fits or that doesn't fit. Because sometimes they'll have very, very strange theories.
And avoiding doing a specific thing because they think that that's your educate them that process.
Yes, or they can still do that, but they need to do it in a slightly different way.
If it is actually quite good. Yeah. So do you think there's a lot of that reflection tasks happening. So
I think it's a lot of treatment and a general non-pregnant team. Yeah, so it's also alternative grouping that people are really pulling in ropes or pushing through that area. Really smart and school colleagues. Yeah. And it doesn't necessarily take a whole lot to tip it into. It was just a bit annoying, and now it's really problematic.
So Grace, alternate Grace is firstly to work out what the activity is that's causing the symptoms, and also at night, if required, yes, stop doing the upside down. Yeah. Particularly bilateral, you can keep one straight going up at another place. Yeah. Okay, so let's do the 75-year-old gentleman from Merida who has diabetes and likes to do a liquor full time. We do what do you do when you information? Yeah. He's like really he's not retired slowly. Yeah. And I believe that's his head couple of years, and he's been using a bony knife at work for a very long time. Yes, yes. Or that, you've just taken up with that and you know he's got more time. Yes. And you've been giving the hard work. Yeah. So it's a fresh start. He's starting fresh. Well, he knew. It's very late. It's very is it? Nice and soft. Yeah. And he has 4 beers every night. Oh yes, I do ask him if he deserves that. When he was a young man. In a safe place at night and he's been and his beers. I'd be also just checking that he knows about it, haven't got sugar levels and things like that. And it's absolutely astounding and difficult. Don't understand the correct and real prebiotic kind of stuff, or they're waiting for the doctor to prescribe them something they don't know something that is good bad. Yes, yes, they're just sort of waiting. Yeah, to get that information. Yeah, the doctor. Getting close to needing that. Yes.
We ignore it as long as we can. Yes.
I have to say that recently, about family members, they were saying that this was up to pre-diabetic and I know we should be having a city dietitian. Oh, you can do it. Yes, it was quite novel. Probably helping being I do feel that sometimes the GP gets stuck on who else can I refer to, and they think of what other doctor you are referred to. They're not necessarily thinking of who else in the healthcare team, you want like allied health could be helping here. The trick is, I do a lot of referring, but I don't know if they actually go. No, often I get letters and then the people never show. Yeah. So I've started to try and send a letter and make sure the letter goes. Yes, that's helpful. Because we're waiting for it. Yeah. And obviously funding human issues. Yes. I mean, particularly from a lot of funding. Yes. Yeah. It's not thing. Not to see that early. So if I do ask every single patient if they started asking them if they drink alcohol, my most common answer is no. I don't know what that means, but it's no, a flat no. I do get, and so now I'm taking to writing down what they say. So they say no. Sometimes they say yes. Sometimes they say absolutely. And it goes on from there as their description. They never tell me how much they drink. Maybe you should ask them because by saying, do you drink alcohol? Yes, no, I mean, I should say no. But if you say, how much do you drink? You say, oh, obviously she's having it once too, is okay. I'll tell her, oh, it's. And what does it mean to you when they say they do drink? What does that mean?
I think that alcohol is neurotoxic, and so if they have a long recovery post-operatively, and I see that they drink, not just a yes answer, but they say, you've got to be kidding, of course I drink buttloads, then I know that they don't have surgical neuropraxis, but they may have alcohol neuropathy. So therefore, I don't worry too much if they have slow recovery. So that's why I want to go forward, because what I need to know is recovery time. So every patient expects to be better tomorrow. And so if they come in a week and they say, I've still got comparison, how long their onset of symptoms were roughly. So, if they say I've been putting up with waking 7 nights a week for a year and a half, then I don't expect to get better after their release. But if they say, like fish, which I said yet, then and if they smoke, then I know that there's going to be slow recovery time, and I can gauge whether or not, we don't want to see them, we want to see them tomorrow, then worry about nerve injury, we don't want to see them. That's why.
So, so much about the alcohol that interferes with my job. The increased inflammatory overnight and the stiffness and aching the next morning. I've had people who, oh yeah, I'm better, but every morning I wake up with this, and then they've had the 4 beers every night, and then you go, I want to try not doing that, and then they'll come back and no. Like that whole process of ingesting that amount of alcohol gives them that ache in the morning and stiffness. Because it fires up your inflammatory cytokines.
One of the equivalent bad always would be, whether sugar, I may not drink a lot, but maybe I have too much sugar in my diet.
And sadly, when we have it, like the work other ones, they'll have the injury, and you watch them, they will put on
10 kilos.
10 kilos.
Yeah, 6 months.
And you go, that is increased inflammatory. And then what are they doing? They're sitting around drinking because it actually feels better when I have a drinks at night,
Pain goes away.
But I don't realize
it's the non-construction when they smoke a bit.
Yeah, so all this happens, and then they go to bed and they sleep, they fall asleep, dead to sleep, but then the alcohol, after a little while, kicks in and disturbs sleep. So they'll have the dead for a while, sleep and whatever, and then they'll have that, and then they'll wake up. Yeah.
What one kind of
So one of our dual clients where we're doing this, but he actually had worked out, and drinking much less pain. So like if someone comes in and they're blaming you for how much pain they're in, ask them a few questions about lifestyle, and then you can turn it back on. And then
I can see that.
Yes.
Yeah, true. Yeah, I try very hard to stay out of class. They do.
That's our job.
But they're right now. And no one's talking.
And that's the good in a podcast. And Joe Rogan. And how many times you've actually told someone, you should give up smoking situations and actually I haven't.
Yes, it's true.
You go, but I don't not. You just
This is sort of overlaid. I come to you because you're a treatment.
Well, correct. Yeah.
And you write a script or you do something to make me better instead of I take responsibility, accountability for our environment.
Absolutely.
And my own injury.
But I think the newer generation are very prepared to take
Yes.
those. You need to bring it back. But we can't assume they're not going to take that on. We need to say, hey, you're a part of this, you've got to be here, I'm not just a coach. You know,
one of the reasons I left physio 20 years ago.
Yeah,
Is because people take responsibility for their own rehabilitation.
So there's still some of that, but there will be others that are very prepared to take more on.
I don't like the idea of sending someone to physiotherapy. I send someone to see a physiotherapist. Physiotherapists then prescribe it as treatment that the patient then has to undertake. They don't just get physio.
My number one these days is lifestyle, joint protection, and lifestyle. You know, like, and optimal loading. That's what I do. You know, like, I mean, that's what works because you can't do it yourself. That's those things they take away and do it. Yes. You know, so that's just so much power. Then, you know, they'll all, if you tell them, you know, we found that this happens, and no, it's rubbish, and then they do that, and it happens. Maybe, you know, you try. You know, sometimes you have a little go at it.
Can you plant the seed?
And maybe it's not me. They come and they talk to you and you sort of everyone seems to tell me that it's what you're country. We'll cut that down. That's it. So, yeah. They can do it.
I think you're going to want to talk about something. Yeah. What do you want to talk about? Workplace. How do you know? Okay, so thing is good. It's to 55-year-old white-handed had his open carpal tunnel, and he's now 6 weeks post surgery, and the surgeon is unhappy with his outcome and sent him for occupational therapy. Sent him for therapy. Good. So we can assess and see what's going on. What we'll probably see is whether it's open or endoscopic, we'll see a lot of scar tissue forming deep underneath. So often I'll say the surface is looking very nice, but it's the adhesions or the cobwebs underneath that are kind of anchoring stuff down and making it move. So we might just get them doing some very light, deep, as they tolerate, deep circles all through that whole area, not just over the scar or what's at other places. Then so we want them to not just do over the scar, but this whole area all around, because that area will be slightly deep. We might then get them doing barrier releases, so going into 4 different directions barrier. So we're going to push the barrier and slide against the other way, and so it's sort of going into 4 different directions. A lot of them call it the north, south, east, west. So then after a while, and they've got used to that, maybe a couple of weeks, we might get in there and get them to try and do a shooting back of the head, pinch it up and roll it. So we're not pinching the skin tight, but we're taking a chunk inside the curve. So we pick it up through the roll against itself, move that way and so that we're getting the adhesion first. And that then helps the structure complete. What are you telling about the exercise? We go through body exercises so that they need to be doing active assisted positions down position, inspiration, into the book. And the book's particularly important because it will take the intrinsics out of the tunnel. So doing that, so we want full flexion of the IPs, the hyperextension that we is covered in place in that. That's a good one. So you're straight and is so really? So we want to use this straight platform. Straight fist. They're not straight fist. Just getting different line. Fork. Yeah. So very good. And then we would go over the assessing the line. So often the way I do that is to look at how
how they can begin this position. So there's more formal ways of testing this before that beginners will get that, but if we start with the exercise, then I'll get used. So I call this doing the course, meaning the beginning, you Saturday, he said, call it something that makes sense to you. So I said, this is baby bear, it's 3 bears. So we bring it out, baby bear down low, and then we bring it back. And then we bring it out to mama bear, and then we bring it back. And then we bring it up to papa bear, and then we bring it back. Now, some of them can't handle that. So straight. So all about the grading. There's no passive movement, no passive breastfeeding. It's the wall tightening up too much because they will not cope with that. So we just get it sliding. We want sliding, gliding tissues, and just doing that very gently. And then we'll, after a week or maybe a week, we'll then bring them into supination and this in the same position. So they won't remember if I say, you're doing it in your nurse line, so but if I say, you're doing the 3 bears, then, oh, yeah, oh, that other bear one, that's before. Right. Yeah, not a shot there. I don't know what it is in my analogies, but they're just quite funny. Short token. My token. What are we going to do to keep in this? So we've got to tiptoe around and then do just the right amount so that the bear doesn't wake up and get cranky. Do not go and poke the bear with a stick. So, don't go and do bring the bus. Yeah. So it's just but that may be the edge. And then the latest stuff from Laura Mosley, us who were talking about, the just right principle, sweet spot, the golden box principle. So there's another. Yes. So we might, the other thing, scar tissue, we might use the advancement mat, so the and that is somehow naturally grey over the scar. Then you might, the patient gets really grey about hand where they might otherwise be the thing, so it makes them more capable of doing the handling and that kind of thing. So you've got to do this really educated approach, Apparently in Germany they like using forks. So one of our colleagues came back from the German conference, international conference in Germany, and they were probably using forks when they start. So now I have to do with not. Now I'm finding this bringing forks. So that's quite funny. And it's just a different way of, and it's to have a smooth edge condition for the work. But my favourite is spiky ball. Not out of spiky ball that sometimes you can get in the therapy supplies. It's got to be hollow. Okay. But the other thing is, if they're not able to do that, it works real treat, but they can also control it by doing this. The soft. If it's too much all at once, then the tuber grip go. So we can stick it in a little bit of tuber grip or in a sock. Nobody advanced that. So it's in the sock, it dumps it down. So then it doesn't feel quite funny. Okay, so it's brittle. Okay, it does feel brittle. Okay. Yeah, it's not a big it's not like the rollers might be using on the tight muscle. You can control this. Then control it. The other thing, they may be hypersensitive, so we might be gradually increasing up to this, and then we might deliberately have to increase. I mean, that's our vibrator, and initially we may just come at it by placing it nearby, or we might have it wrapped in 4 layers of towel and nearby, or we might even be so far as that we'll put it on the gym next time, not even touching. Because that's all they can handle. So whatever they can handle, then braid it down so that they can eventually can hold it, and then eventually can use it.
Have you found if the worst they are to want to know the worst they are afterwards?
Then when you say still like sensitive, I'll just have an inversion back in and it may never, well, if you can down, and then move the machine, shouldn't necessarily stiff, stiff. So getting rid of that scar tissue so that things fly better means that but the longer their hand is swollen and they don't move, they're denser and more fibrotic, and but we can usually get that back, even if they can't. But most of the time we'll get some better sensation. Then we might, this is one of my favourite things that's very clever, but not used very often, but it's complex foam from the we're using the cadet management, but it's, I call it channel foam because it's channels, but we can cut it to size and it's washable, and we can cut it into the peanut so that under the glove where there might be a pocket or in here or a bit of density over here, we can pull it down over there to bring it there. Just little inserts and things like that to make a difference. I've got time for one more patient. Yes. 40-year-old typist wants to know what she needs to do to modify the test for the videos. Okay. We're not going to go through what are they doing now and after that and the neutral body positions and setting themselves up right, and with everyone having multiple different workplaces or like home this work or hot this things like that is a real problem. But you know, it's like most things are adjustable. Most workplaces have stuff that's adjustable. No one ever adjusts it. So the number of times I walk into to go through things that the GP, the division of GPs around it, every single time I would go in there, I would adjust another chair. So by the time I finished going through things for over many years, most of the chairs have been adjusted. No one had ever really adjusted them. But at least they maybe doesn't become their bought position with the backrest fully down and the seat not right. And adjust the height, make it right. So you're in the neutral position, their shoulders relaxed on the side, not acting with the mouse. Yes, but if they're particularly problematic, say it's a right hand that's problematic, this might problematic. It's your favourite quality of the mouse, yeah. He's my favourite, but it's not the only one.
So what office first things?
No, this one is not from office first, but there are versions that are more accessible these days.
They're not that hard to find.
No, but you can definitely
Daily Wi-Fi.
Yeah. So that we want to. There's nothing wrong with the conventional maths, except if you're doing this constantly. Okay. So we want to be using our bigger muscles up here to move around, not here and not over there.
No, that's slide.
Yeah, yeah. So we want to think about sit right at the table, so you can be at the desk, and the desk at the right height, and then the desk can be adjusted. You know, my chair can be so that my shoulder is relaxed and my forearm is level, and as I'm there, I'm doing this. Now I actually do this on my right because my treatment table is a treatment table as well as a computer desk. So mine's on this side. That's right, specifically, and I prefer the cordless one, but sometimes the corded one is actually lighter. So, but this is good because it's a bit more neutral. It stops you doing this straddling around. It's fun. The fingers resting, just naturally are doing this. So it's not for everyone, but it's just one of the options. Just, and I shouldn't say just because the things that are written in the label, ergonomic doesn't have ergonomic. Ergonomic is about the fit of the person in their environment. Yes. Just the same way that the cheese at the supermarket is labelled light or healthy or whatever, any of those things. So, I might also say to the person who's saying, I'm having trouble opening it up, I have to show you. I show you. This is one of my favouriteest little gadgets. But if we have a jar that I might set up quite tight, so that's quite tight, this is the quite small version of this, and I just press it right at the hold it, placing on the lid, placing on the jar, and does a kind think there was
They could just need to be designed.
yeah. So a lot of that. I saw it.
So this lady goes to me, so she locked her up for maybe 6 months before, and she had all these jars in her house she couldn't undo because she would always hand the jar to her husband. Yes. Yeah, but I mean, it's.
And yeah, if you've got someone else who looks like, oh, you might get because I want to see it over it. And they'll come tonight and they'll look and have it tomorrow. There's no one there. Yeah. And even this is simple built up group can make all the difference. So if the hand is a bit stiff after surgery or limited alcohol, or speed. So I had someone today who got really stiff after their surgery, and we were talking about what are they going to get eating. So yeah. So right, puts that all in the built up, and then he's going to have a good enough group to hold it while he's actually cutting with the knife and cutting. Take the knife in the third hand, yeah. So but he would normally have a knife in that hand there, so it's easier to use.
I think they're going to get through most of the problems.
But there's more.